Welcome everybody to morning's residents lecture round. Today our resident Janina Quito will present to you a quite difficult topic on chronic pancreatitis with a lot of debates still ongoing. She's a fourth-year resident and now since 2.5 years in our clinic. Welcome and thank you for the talk.
Thank you very much, Christian, for your lovely introduction. So, as just mentioned, today it's my pleasure to talk about the chronic pancreatitis. First, I want to define the chronic pancreatitis, then we jump over to diagnostic main symptoms, therapeutic approaches, as well as recent studies, and then we draw a conclusion. So, the chronic pancreatitis is defined as a multifactorial fibroinflammatory syndrome in which repetitive episodes of pancreatic inflammation lead to extensive fibrotic tissue replacement. This causing in patients chronic pain with recurrent hospitalizations, meaning for the patient a reduced quality of life and an incapability to work, having economical relevance by lastly 50,000 hospitalizations per year in Germany. And as well causing an excellent endocrine insufficiency with malnutrition, weight loss, diabetes, and a shorter life expectancy. And the chronic pancreatitis has an increased lifetime risk for cancer up to 4%, according to the International Pancreatic Study Group. So when we talk about the etiology, it's thought that most cases of chronic pancreatitis derive from alcohol consumption. Well, actually it's believed that 70 to 80% come from alcohol consumption, over 80 grams per day over at least 12 years. Smoking is not a risk factor on its own, but an aggravating factor. Research has been done on genes, and there has been found of some genes. So there is also hereditary reason for chronic pancreatitis, as well as an autoimmune idiopathic cause. There is a tropical pancreatitis not found in our hemisphere, but still there is one in Asia and Africa. And there is a pancreas division, also cause for pancreatitis. There are some obstructive reasons. And last but not least, and very important to know, if a patient suffers from primary hyperparathyroidism, it's also 20 times fold higher risk to get a chronic pancreatitis due to the calcification of the duct in the parenchyma. So when we could talk about the pathogenesis, the recurrent inflammation causes a fibrotic replacement of the functional pancreatic tissue. This causes in the pancreas morphological changes, as I said before, calcification, strictures, stenosis of the duct, and beforehand dilatation of the duct, as well as pseudocysts. Concerning the surrounding organs, we will find the stenosis of the duodenum, vascular complications, and maybe compression of the bile duct as well. Nutrition-wise, as I said before, we'll find the diabetes. And it's very important to notice that that kind of diabetes is different from diabetes mellitus, because there's also lack of alpha glucagon cells, which can cause severe hypoglycemia as well. As well, there's found malnutrition, weight loss, osteoporosis, lack of vitamin D and E, and as I said before, there's an increased lifetime risk for cancer. So when we talk about diagnostics, of course, if we have the suspicion of chronic pancreatitis, we must always start with patient history. Is there risk factors like alcohol consumption? Or then we would do the clinical examination and we would go for diagnostics like, for instance, ultrasound. But in many cases, the ultrasound remains unclear, so we would go for endo-ultrasound as seen in picture A and B. There we would have a dilated pancreatic duct shown with the arrowheads and maybe calcification shown with the asterisks. And C, you would see a CT scan but also calcification of the pancreatic duct or widening of the pancreatic duct. And in D, we see an MRCP also with a dilated duct and the asterisk points at some pseudocysts. So diagnostic can be made by imaging alone or with at least two of the following clinical features, like repeated upper abdominal pain or abnormal serum or urine pancreas enzyme concentration. The therapeutic approach of chronic pancreatitis is a step-up approach. According to the recent guideline, we would start off with lifestyle changes, meaning dietary change, go for a low-fat diet, and of course cessation of alcohol consumption and smoking. Then we would add some supportive medication, and if that is not enough, we would go for pain medication. And according to the WHO pain relief letter, we would start with non-opioids and add, if that's not enough, co-energetics like neuroleptica or antidepressants. And lastly, go over to opioids. But we would try to avoid those as long as possible because of the adverse effects like misuse, nausea, vomiting. If that is still not enough and there's still failure in therapy, we would go to endoscopic interventions and lastly to surgical interventions. So to repeat that again, the main symptom of chronic pancreatitis is the chronic belt-shaped pain. And there are two mechanisms to be believed how the pain derives. The first one is, due to accumulation of secretions, there's the raising pressure in the parenchyma causing pain. And the second is, due to the chronic inflammation, the cytotoxic cell activity is increased and immune cell infiltration is happening. Both mechanisms can cause neuromodulation, which means there's a rise in diameter and density of nerve fibers around the pancreatic head. This can cause a stimulus-independent autonomical visceral pain, leading to a formation of pain memory, which might be irreversible. So it's very important to notice that the therapeutic approaches address directly the mechanisms of pain. First, if there's a raising pressure in parenchyma, we would do a drainage procedure for pain release. Secondary, if there is some chronic inflammation area, we would go for resection of those areas to avoid recurrent pain, chronification of pain, as well as cancer. And a special role has the fibrosis in the pancreatic head, as this is believed to be the pacemaker of pain. So which are the indications for endoscopic and surgical interventions? Well, there's only one indication, which is the chronic abdominal pain, which is, as I said before, unresponsive to non-opioid therapy. And the intervention should be done within weeks after starting opioids, very early, to avoid the formation of pain memory. And there's still an ongoing debate, as Christian just mentioned in the beginning, about surgery versus endoscopic intervention. So when it comes to endoscopic treatment, there are two main indications for endoscopic, which is pancreatic stone extraction plus minus stenting and the biliary stenosis. And according to an article of Bayard or published 2020 in Lancet, pancreatic stone extraction endoscopically is a good idea if there are no more than 3 stones, if they are only located in the head and neck of the pancreas. Maybe you have to perform a shockwave lithotripsy as well, one time or more often if the stones are bigger than 7 millimeters. This should clear stones by 54 to 100% and should have a good opioid reduction by 80% in patients. Due to the same article, there was a meta-analysis of 22 cohort studies in which benign common bile duct stenosis was examined, and it has been shown that self-expanding metal stents are a good idea for biliary stenosis, as they have excellent long-term results in the pain resolution by 83%. Actually, one could use plastic stents as well, but they require more often changing, so more interventions for the patients. So when we talk about pseudocysts, there's also a role of intervention, but not every pseudocyst has to undergo treatment. The indications for treatments are if they are symptomatic, if they are larger than 4 centimeters, and if they're persistent for more than 3 to 6 months. You could go for endoscopic treatment and do a transmural drainage in stomach or duodenum, but one have to place double pigtail stents there to prevent recurrence, and they have to stay at least for 3 months. But they have to be changed every 8 to 12 weeks, meaning a lot of interventions for the patients as well. There are some contraindications for endoscopic approach. If there was vascular complications, then you would go for surgery directly. But in our center, and I want to point that out, we'd like to do the surgical cystodynostomy first. But it's still indicated if endoscopy fails or is contraindicated, and if there are pseudocysts with simultaneous pancreatic duct changes, because they have a high risk of recurrence of pseudocysts. So I just want to show you now a very nice patient example from a patient that had a pancreatic pseudocyst. Here you see the CT scan of the patient, having a large pseudocyst just underneath the stomach, pushing the stomach aside. And this patient was suffering from nausea, he was not able to eat, and he had a recurrent pain. And this patient so the pseudocyst was symptomatic. It was persisting for more than 3 months in the CT scan follow-up. And the pseudocyst didn't change in size. So what did we do here? We did a robotic cystodynostomy. Here are some intraoperative pictures. Here you see the pseudocyst. Here the pseudocyst wall is opened. Here a jejunal loop is mobilized and sutured on the pseudocyst. And these are the very nice postoperative pictures. In the CT scan, you cannot see the pseudocyst anymore. And as you see in the lower part of the picture, the abdomen is pretty flat, very nice postoperative picture. So what is the role of surgery in chronic pancreatitis? Of course, if we have the suspicion of malignoma, we would go for surgery directly. If the endoscopy fails due to recent guidelines, if patients have persisting pain or local complications, or if there are pseudocysts, as I mentioned before, with simultaneous duct changes. And surgical intervention has been an effective treatment of refractory pain and or local complications. So when we talk about surgical treatment, we have to be aware of what kind of surgical treatment we want to choose. And actually, this is dependent on the duct size. So we go to the left part of the diagram now. If the pancreatic duct is small and there is no confirmed malignancy, we would go for Frey and Berger, dependent on the presence of multiple strictures. But at our center, we prefer the Frey procedure. If you have multiple strictures, you would have the chain of legs sign as shown in the lower part of the picture. If there is a suspicion of malignancy, we would go for Whipple directly. Now we come to the right part of the diagram. If the duct size is large and there is a pancreatic head dominance, we would go for Frey pancreatic jejunostomy. If the head is not dominant, we would go for Partington-Rochelle. I will show you now the Partington-Rochelle maneuver or procedure. There it is. So the procedure is shown here. We will perform a longitudinal opening of the pancreatic duct and perform a pancreatic jejunostomy without the pancreatic head involvement. And this is only recommended if the duct size is larger than 7 millimeters, if there's no inflammatory mass at the pancreatic head, thus being just indicated in less than 10% of cases. But it has been shown to be a good, or has a good outcome in primary pain relief. And it's necessary procedure in distal stones or if there are more than 3 pancreatic stones. Now we move on to the most often performed procedure in our center, which is the Frey procedure. I just want to show you the surgical way how to do it. First, we want to locate the pancreatic duct with a syringe and as well perform a longitudinal opening of the pancreatic duct. But we go until the ampulla and check whether it's passable, the papilla, sorry. Then we would do a drainage of the whole duct, as shown here. And then as well do a pancreatic jejunostomy side to side, and lastly perform a footprint anastomosis. Here we have a very nice picture from the OR when we did a Frey procedure with one of our patients, and you see here the very wide dilated pancreatic duct. So when it comes to chronic pancreatitis, one can ask, why don't we do a Whipple procedure? Well, both procedures, Frey and Whipple, has been shown equally in pain and complications, but the Frey maneuver has, due to the partial resection, because it's a duodenum preserving procedure, a shorter hospital stay, and patients experience a quicker rehabilitation. So if there's a pancreatic head enlargement and the bile dilatation, we would go for Frey, which is the duodenum preserving procedure, and it's shown here. But if you have any suspicion of melanoma, we would go for a Koch Whipple procedure directly. So now I just want to show you some recent studies about the role of surgical or endoscopic intervention. Let's start with this RCT, which was published in New England Journal of Medicine in 2007. The patient number is quite small, by 39, and there was a comparison between endoscopic and surgical drainage of the pancreatic duct. No resection maneuvers here. And what we can see here was that after surgical treatment, patients suffered from a lower pain scale. Its-Bicky pain score was used, a better physical health, and the complete or partial pain relief was found in 75%, comparing 32% in the endoscopic group, making the surgical drainage more effective treatment than the endoscopic treatment in this study. The next study I want to show you, it's also an RCT, was published in Endoscopy 2003. Here there was a comparison between pain relief, body weight development, and frequency of onset of diabetes mellitus in patients treated with surgical treatment, resection and drainage in this paper, and with endoscopic treatment. And what you can see here is that the surgical group experienced a significant more frequent complete absence of pain, and also a quicker increase of body weight, suggesting maybe that the endocrine function was better in the surgical group after treatment. Last study I want to show you is the ESCAPE trial. That was just published last year in spring 2020 in the Journal of American Medical Association, and it was comparing the endoscopy first approach according to recent guidelines to the early surgical approach. And the comparison was made in terms of pain relief, pancreatic function, and as well as number of interventions. And what are the results? Actually, we'll find a complete or partial pain relief in 58% in early surgery group versus 39% in endoscopy group. The number of intervention was less in surgical group, like 1 median, versus 3 in endoscopic group, but there were no differences in complications, mortality, hospital admissions, or pancreatic function and quality of life. So if I want to conclude that for you, and this is the last slide, the chronic pancreatitis is a common disease and an often cause for hospitalization. Due to lots of days on sick leave, it has a high economical relevance. And pain is the only indication for surgery deriving from complications as strictures, calcification, pancreatic stones, dilated main pancreatic duct. The Whipple procedure is performed just rare in chronic pancreatitis unless there's the suspicion of cancer. And there's weak level of evidence suggesting that early surgical intervention is a good alternative to endoscopy. So maybe, and I just want to leave that open, we should overthink the role of gastroenterologists as a gatekeeper for chronic pancreatitis. Thank you for your attention.
Thank you. Difficult topic. And I think you very well highlight what should be done and what is really done. I mean, here there is, number one, a huge bias in reporting. You should a randomized trial. I think that's the only one we may follow. Sample size is very small and is highly dependent of the quality or the experience of gastroenterologist, of surgeon. The real world could be very different. And very importantly, you show that the complication, and I think that's what most observe following endoscopic procedure, is as high than it is with surgery. Usually you can do anastomosis in this hard pancreas with very little complication, very low risk of fistula. And now we do it with the robot, as you show, which probably will even decrease the complication, or at least patient will stay less in the hospital. So clearly, I think what you show, surgery is still today, from the evidence, is the first line and not the second line. Yet, this is not what happened, because we don't receive this patient. They go to gastroenterologists. There is, and we don't know. I think no one in the world. In the Netherlands, they're a bit better organized, but also in the Netherlands, we have absolutely no clue how many patients have chronic pancreatitis, how many had even conservative or the endoscopic versus surgery. I mean, in Zurich, we even suffer a little bit from leadership in this area. In the 80s, Professor Ammann was the head of gastroenterology here, published a landmark paper in gastroenterology, basically saying, just wait and see, the pancreas will burn and the pain goes away, so don't operate. And that has stayed for a long, long time. I think it's not only in Zurich, so we refer this patient very rarely to us. We do some, but it's pretty rare. The cancer can happen. This is usually difficult diagnosis, so I will not go on that. It's rarely an indication, can be if you're a positive PET lesion somewhere in the pancreas. But I think this is a difficult, really, topic, and patients are not optimally treated, not offered surgery, and you've shown 80%. It's very impressive. Really is often, if we do it too late, patient cachectic, of course, you have more problems. If they come as the last possibility, then they may be even too late for surgery, with a high risk of problems due to the very poor condition, malnutrition, etc. So, this talk should be given to gastroenterologists, to generalists, or in the society, that they know this is a big problem in this country and others, because the alcohol consumption. And I think this would be very good that there is somewhat a campaign that people can know and refer to surgery. That should also go in center with experience. I mean, this is not a surgery for general surgeons who do not operate on pancreas. It has to be done by expert or center with volume in the field, where you have gastroenterologists and everything to do that. And this is a very, very new and very good area for robotic surgery. It was done laparoscopically, and now many of those. The pseudocyst is a complete different topic. I mean, you wanted to cover that. This is a complication from acute pancreatitis. Usually you presented that. And we do also, we look where is the cyst, and if it's really in the stomach, we do also gastrocystostomy if it's needed in this area. I don't know if there is question. I don't have a specific question here, but if there are comments.
Yes, Janina, thank you very much. Very nice talk. I have a question. What is the role for total pancreatectomy or partial pancreatectomy, like Whipple or left pancreatectomy, in patients with pain only, without suspicion of malignancy? Is there any role for any of those procedures?
I can take it if you want. There is. So this is not. This is a good question. There is. There is interest. We've also done a few here of patient with total pancreatectomy, and then you isolate the islet and you re-inject the islet to minimize at least the diabetes after. In this total pancreatectomy is not easy. This chronic pancreatitis, technically, and this is often that difficult. And if the duct is dilated, then we prefer drainage. I mean, the treatment is really the drainage. As different procedures. I think now the most accepted is to believe there is some pacemaker in the head, so you open the Wirsung, and then you resect a bit the head and you do a very wide anastomosis. So there is little indication for a total pancreatectomy, and sometimes it's done as a second procedure. You do a first drainage and then you go. We've done in young patients total pancreatectomy, isolation of the islet, which is not easy because the islet are in the middle of fibrosis, but this is done by some centers, and there are some interesting data where rarely you completely prevent diabetes, but you make it, easier to treat.
I have a question regarding pseudocysts, because I mean this is all a very individualized therapy. You have endoscopic treatment, surgical treatment, different surgical procedures, and there are those cases where you have a large pseudocyst in the bursa orbitalis, and maybe I missed this. There's also the option to do a simple transgastric endoscopic drainage procedure. Sorry, so I missed this. But this is maybe a little bit different situation than here with chronic pancreatitis. Okay, so I just wanted to ask us if this is still a valuable option.
You mean if we should drain gastric or not? Yeah, I mean this is still on debate. If I may say, there is the negative part is it seems to be a small procedure endoscopically to puncture through the stomach and drain the pseudocyst, although this has a lot of complications and re-endoscopy for the patient. So it's never solved with one endoscopy. They usually go 3, 4, 5 times to redo and to change their stents. They have this self-expanding, now the SEMS metal stents, which are a little bit better than the plastic stents they used before to drain. There's no randomized trial comparing one of each other. But what is known is that in surgery, you have usually median 1 operation to drain the pseudocyst, and the complication, hospital readmission, is lower compared to endoscopic procedures. Therefore, I would say still, although at the beginning it seems a bigger operation, or let's see, a more invasive procedure, it's much better at the end to perform surgery to stereostomy compared to the endoscopic drains.
Okay, all right, thank you.
Thank you.